Good day, my dear students. Welcome to Rats in Pathology for Postgraduates. Today's class shall be on the interpretation of renal biopsies. There are a plethora of pictures that are going to stare at us. I hope you will be able to unveil the mysteries that they have in them. Do not be baffled by the numerous words that are there on the screen. These are all various normal components or terms with which we should be familiar, or mostly you are familiar. Just try to recapitulate them. And in the red box, you have got some conditions where they can be applied. Basically, whenever you try to interpret a biopsy, you will have to find out whether it is a congenital lesion, a neoplastic lesion, a reaction to injury, or it is a healing or a fibrosing process. And under each of these, you will be having a series of conditions which you will have to identify. Again, a lot of terms are here which I have numbered, and I will also be illustrating on the screens. For example, the thickening of the basement membrane, a thin basement membrane, immunofluorescence, electron microscopy, so on and so forth. A normal histology, you people are all very familiar with, no more wastage of time. But then this is a higher magnification of the glomerulus, which is a tuft of capillaries that is trying to filter the urine, which is an ultrafiltrate of the plasma. And in each of the capillaries, I told you that there is something unique. You have got an endothelium and an epithelium, which is separated by a basement membrane. And this originates from the mesangium. Externally, we find the parietal space or the Bowman space. From the University of Michigan, sometimes the histology pictures from them are all magnificent. But I would be very happy if you can appreciate a difference between this tubule and this and this. So you find that there are different types of tubules. Externally, there is a capsule. Glomerulus by itself has got a capsule. There are the tubules, the blood vessels, and the interstitium or the intervening tissue. So look at it over here. I am finding the glomerulus and the various tubules. I hope you are able to identify these elements. The first lesion I shall go into will be the infectious diseases, the most common ones. Now, as a student, when you are asked about the interpretation, if you can write what you can recall and what the undergraduate questions are, it is more than enough. Then I shall be going to infectious glomerulonephritis, which can be post-streptococcal or staphylococcal glomerulonephritis, in which there can be a proliferation of the endothelium, epithelium, and the mesangial cells. 3. So, being an infection, there will be an inflammation, and you will be able to see the neutrophils over here. There will also be some amount of filling in of the space, but no crescent formation initially. Under electron microscopy, I'll be able to see something different, and the condition itself is a nephritic syndrome, which can be a university essay question for you. And what are the other tests you people will have to read up. And this incidentally is the electron microscopic picture that is showing the sub-epithelial hump. As I told you, there is a basement membrane, there is an epithelium, there is an endothelium for each capillary. There is a different type of parietal epithelium, which we shall see later. The second group of diseases will be vascular diseases. Under vascular diseases, you have got benign and malignant. Benign nephrosclerosis, malignant nephrosclerosis. Okay. The granular contracted kidney, bilateral, symmetrical, fine. That can be there. Also, I find that there can be two features in the case of malignant nephrosclerosis. One is an onion skin appearance, or there can be a vasculitis with a necrosis, producing what is called as a flea-bitten kidney. Externally, I'll be able to find multiple punctate or ecchymotic patches on the capsule. This is not sufficient. What else do I have in the vascular diseases? Under hypertension, there is something called as hyalinization. Hyalinization is the homogenization of the vessel wall. That is classical of it in any hypertension. Also, this can be seen in diabetes. In a diabetic kidney also, there can be hyalinization of the blood vessels. So, what are the other vascular lesions? It can be SLE, fibrinoid necrosis in hinox condylarthritis purpura or malignant hypertension, hyalin sclerosis, cholesterol emboli, and sometimes you find that there can be swollen endothelial cells in a case of eclampsia. So, always have a list with you. Vascular diseases mean it does not mean only nephrosclerosis. There can be so many other conditions. The moment you are able to recollect the conditions, you will be able to recollect the features also. See this for example. When I say vasculitis, this is more pertinent. I find that there is a small caliber blood vessel and there is a fibrinoid necrosis that is breaching through the wall. That can be the courtesy is this. And also I find that there is a small crescent that is being formed at the external aspect of the glomerulus. And here also, these are also blood vessels, the tufts of capillaries, wherein I find some kind of vasculitis called as glomerulonephritis. So this is one. Diabetic kidney. Whenever I say diabetic kidney, common thing that they ask you in the clinical pathology as well. What are all the changes? So this is one instance wherein I have got a hyalin cap over each of this capillary tufts over here. Hyalin caps. So you can get nodular glomerulosclerosis or the Kemmel-Still-Wilson lesion. It can be focal, segmental. There can be hyalinization of the blood vessels, fibrin cap, capsular drops, necrotizing papillitis, or many Epstein lesions. These you people shall and will answer in the exam or anywhere else. Glomerulosclerosis can be focal, it can be segmental. Here a large segment, nearly more than 50% of the glomerulus is getting involved in it. This is not a crescent. Crescent will be seen over here in the Bowman space. But later on, however, there can be a crescentic glomerulonephritis even in a case of diabetes. And what is the stain you people shall identify? Nodular, when it is going to be appearing as a small nodule. So smaller than a segmental one. Basement membrane thickening. So any of the basement membrane, you find that there is thickening. In fact, the glomerular capillary basement membrane is also thickened in a case of diabetes, but in spite of which there is leakage, the patient will be having a proteinuria, he will be having a glycosuria. Why it is, you people shall read up. Again, nodular lesion, the classical Kemmel-Still-Wilson lesion. I find multiple nodules over there. They may be involving a good number of the glomeruli, but need not necessarily be so in all the glomeruli. One of the classical lesions that we see, it is a kind of an acute pyelonephritis, but then a variant called as necrotizing papillitis, classical of diabetes. It occurs at the renal pyramid. There is a definite line of cleavage between the normal and the necrotic zone at the apex of the pyramids. Necrotizing papillitis. And this again is our friend the electron microscope that is showing a thickening of the basement membrane in a case of diabetes. As I told you, in spite of the thickening, why is there leakage? The people should be able to answer. My duty is to only take you to the lesions per se. We shall be continuing with the diabetic changes. There are two pictures over here. One is a black and white photograph of a H&E stain. In this, I am finding clear vacuolation in the tubules. What can be the vacuoles? Is it glycogen or is it fat? That is debatable. But then, when a special stain such as musicarmin or PAS is done, it is positive. So it is glycogen that is being reabsorbed in the tubules. Thanks to Arcana Laboratories, this is a fantastic source that you people should always visit. Thanks to them. Also, I would like you people to always remember the special stains. Methylamine silver, there can be sclerosis that is found in the glomeruli that is also being depicted by means of the mesons trichrome. Pyelonephritis. One clear word that you people should remember is this is a tubule within which I am finding a group of neutrophils. Acute pyelonephritis is so. But when it is going to be outside, it can be any other condition such as even a graft rejection. So please remember this in acute pyelonephritis, classical of diabetes. Hyaline caps I have mentioned. There is another condition called as capsular drops. As though something is dropping from the parietal wall, a capsular drop. Thanks to this person whom I have mentioned over here. The next one is rapidly progressive or crescentic glomerulonephritis. Sometimes it can lead to an end-stage kidney. So look at this. There is a total obliteration of the Bowman space, and there is a proliferation of the cells. These are all the parietal epithelial cells that have proliferated. There are important things that you'll have to remember. One is multiplication of the cells or proliferation. Two, there can be deposition of fibrin. Three, there can be complete fibrosis or sclerosis. This can happen in a number of conditions such as Goodpasture syndrome, post-infectious, lupus nephritis, IgA, including the inox-Tonlin purpura. So these are the various stages of it. Distinct crescents, proliferation of the epithelial cells, obliteration of the Bowman space, fibrin strands, leukocytic exudate also can be seen over here, and glomerulosclerosis finally. So this again is a silver stain. Silver stain is always used to demarcate either the capsule or the basement membrane or both. Next is our friend, the nephrotic syndrome. Nephrotic syndrome, always remember that there can be a primary nephrotic syndrome, secondary nephrotic syndrome. Primary, usually the age-old diseases that people all know, starting with the minimal change disease. So this is a beautiful set of diagrams. I've given the reference towards the end. You people can draw them in your exam. So you find that there is a normal capillary. There is an endothelium. There is an epithelium. And these are all the foot processes normally seen. And this gray color is the basement membrane. Externally, there is a mesangial cell, and externally, there is a matrix called the mesangial matrix. Very simple. In this one, compared to this, I find that there is no foot process or the loss of the foot processes. There are different theories of it. You people can go to the text and read. And that is exactly what is being reflected in this also. So there is a capillary over here, the lumen, blood vessel, and externally, I find that there is a fusion of the foot processes or minimal change disease, which is again shown over here. So this is a capillary lumen, external cell, but there is no podocytes that can be seen. There is an effacement. This can be one of the theories, but then I would like to people to go to it. Again, thanks to Arcana Laboratories. The next one is membranous glomerulonephritis. Membranous means you find that there can be a proliferation of the capillaries. It almost fills the lumen, and there is a thickening of the basement membrane. Also, I will be able to see that there are some deposits. This I cannot be seeing in a H&E stain, but when I do a silver stain, probably it can be visible. We shall see. The same picture of the capillary, glomerulus, and in a membranous, I find that there will be the foot processes, and below that you find that the immune complexes get deposited. So basically, there is a deposition of the immune complex which precipitates a series of reactions that leads to the nephrotic syndrome. So sub-epithelial deposits, which is granular. So look at this over here. A silver stain is sometimes recommended, and I will be able to find the projections in the epithelial cells outside. Beautifully shown. And an immunofluorescence is the reinforcement in our armamentarium that will be showing granular deposits. Basically, there are two types of deposits. One is granular, other is linear. Why, we shall be seeing. The next disease is Membranoproliferative glomerulonephritis. So here, the normal capillary, it has got a thin wall as such. And what happens in a case of membranoproliferative? You find that there is a proliferation of the cells. It is not nodular, but then it is uniformly proliferating and fills up the Bowman space. There is an increase in the number of cells. Capillaries are thick-walled. I'll be able to find the eosinophilic material in between, indicating that it is the basement membrane. And the basement membrane also can go to the extent of getting split. Immunofluorescence will be showing a granular positivity. I think you people are able to appreciate a positivity which is again granular and not homogeneous as such. This again is the same. So there is a granular positivity that can be seen over here. Thickening of the capillary wall. This is a thin wall normal capillary. And membranoproliferative, it can lead to a variant called as dense deposit disease. See what is happening over here. There is a mesangium. There is a proliferation of the mesangium. Increase in the mesangial matrix. It develops a deposit, and its interposition is there between the epithelium and the endothelium of the capillaries. Therefore, you get a dense deposit, hence the name dense deposit disease, which can be reflected in the form of a picture in the electron microscope. So also you find that the silver stains are paramount importance in showing the thickness of the basement membrane. Electron microscopic higher magnification is there, which is again showing a thickening of the basement membrane. No crescents are seen in this. So the same thing being summarized, and the points are over here. It is normal. This picture is normal over here, and then the others are nephrotic syndrome. You find that there can be subendothelial deposits also over here, can be granular, and there will be a mesangial interposition that is causing a splitting of it. The next group of diseases will be the IgA nephropathy. IgA nephropathy is a university question for you people, in which one will be of importance will be the proliferation or the thickening of the mesangium over here. All the cellular elements are also getting proliferated, but then there is increased amount of congestion, and sometimes there can be a rupture and a leakage of cells into the Bowman space. I find that there is a leakage of the RBCs that are seen over here. And here also there is a granular deposit found in the mesangium throughout. So this can be a reference. It is otherwise called as a Burgess disease. See what is happening over here. There is the endothelium, the epithelium, the basement membrane is getting thickened, but at the same time there is a rupture of it. There is a vasculitis, probably proliferation of the mesangial cells that are seen. So mesangial deposits, and they say that it is associated with glycosylated hemoglobin or even diabetes. Vasculitis, hematuria can be a classical symptom. Not only is it limited to the glomerulus, but also to the interstitium, producing fibrosis. In the later stages, there can be crescent formation. Chronic infection can lead to either IgG or IgM deposits also. Here it is IgA deposit, and hence the name IgA nephropathy. IgA nephropathy, see what is happening. Patient can present with proteinuria, immune complexes are there, mesangial and endocapillary proliferation, and deposits of these are also seen. dense granular deposits are seen in the mesangium. Another disease will be the tubulointerstitial diseases. So brown and mid. Tubulointerstitium, always have a list of names with you. Pyelonephritis, fine. It can be acute, it can be chronic. It can be graft rejection. It can be viral infection with enlarged nuclei and plasma cells. Eosinophils, again in a case of graft rejection. Or it can be tubular necrosis. Look at this one. These tubules are all viable, something that we teach our students. But here I find that there are some tubules devoid of nuclei, and it is a case of acute tubular necrosis. After the glomeruli and the blood vessels, we go to a group of diseases called tubulointerstitial diseases. It can be acute pyelonephritis, as we had seen, or chronic pyelonephritis, or sometimes it can be a viral infection wherein there is an infiltrate in the interstitium, eosinophils and graft rejection, and acute tubular necrosis. See what we are finding. I am finding a ghost-like outline of the tubules devoid of nuclei. So it is a case of necrosis. There are different types of it. This by itself is a question for you. You people can read up. But remember that acute tubular necrosis is an interstitial disease. Also, you find that when there is going to be an acute inflammatory exudate of neutrophils in the lumen, it indicates acute pyelonephritis, whereas when it is peritubular, it can be because of humoral rejection. Two things alone you remember. Within the lumen, acute pyelonephritis. Without the lumen, peritubular, humoral rejection. There can be an infiltrate of lymphocytes in any case of chronic rejection or chronic pyelonephritis. Also, you will be finding thyroidization of the tubules. Fine. Plasma cells are seen in a case of myeloma or in inflammatory lesions such as tuberculosis or syphilis. It can be mixed in a case of viral etiology. Eosinophils again are of importance whenever there is going to be an allergic reaction, including a hypersensitivity. Now, what are the renal findings in a case of acute renal failure? So this is a case of acute tubular necrosis due to cocaine. I find that there is a dilatation of the cortical tubules over here. And at renal autopsy, when there is a cardiac arrest, there is a disformation of the epithelial cells, and most of the tubules are having dead cells. And immunoperoxidase, you find that there will be attenuated proximal convoluted tubules which are distended, which contrast with the smaller intact tubules. These you people can mention if you do remember. Myeloma kidney. Whenever we talk about myeloma kidney, there are lots of things, including the Bence-Jones protein, so on and so forth. But never did I imagine that can be such a list that can be produced. There can be an amyloidosis, there can be a cast nephropathy, it can be a myeloma protein, or it should be differentiated from a TAM phosphol protein normally found in the kidney. There can be acute tubular necrosis, membranous glomerulonephritis, and interstitial nephropathy. And this incidentally, I find that there is a cast within a tubule. I told you, this is the reference which you people shall go to. And we have been talking about the kappa and the lambda chains. Lambda chain is very strongly positive, both within the tubules as well as in the interstitium and in the periglomerular region. Kappa is not so. So this is again the tubules that you see over here, myeloma cast. And sometimes we'll have to look for any infiltration by the plasma cells. What are all the importance of the trichrome stains you people will have to enumerate? Amyloid, an age-old friend of ours. You find that the organ is enlarged, pale, waxy, shiny, etc. in the early stages. Later on, it can go in for contraction. That is different. But then I'm finding the glomeruli over here and also spreading on to the tubules. There is a pale, homogeneous, eosinophilic acellular material And the differential diagnosis can be hyalinisation or sclerosis. And obviously, we'll have to do some special stains to confirm that it is amyloid, such as this. A Congo red, which is going to be positive for a case of amyloid. Yet another one, the lupus nephritis. This is a little difficult picture. I hope you people will have the patience to see. Otherwise, stop, pause, and again come back. So this is what I am seeing. So the mesangial lupus nephritis, what I am seeing is there is the epithelium, again the endothelium with fenestration, the basement membrane. A minimal change over here, mesangial lupus nephritis. There can be proliferation of the mesangial cells. Immune complexes, of course, can be seen. After all, what is SLE? It is a typical prototype of an autoimmune and an immunological disease. So please do remember. Also, there are spikes over here, and under the epithelial foot processes, I'm able to see the deposits in this case. So it is a membranous lupus nephritis. It can be mesangial, it can be membranous. And look at this, there is a dense thickening because of the mesangial proliferation. Also, I find that there will be the foot processes and then the deposits which are made out by means of electron microscopy. The same picture showing the proliferation, and sometimes there can be the classical wire loop lesion that can be made out. So this is pertinent. You may get a chart showing this. So it can be focal, it can be diffuse, there can be wire loop lesions, mesangial, as well as finally there can be sclerosis that is made out. So these are all important things which we will have to remember. Lupus nephritis. Again, I am seeing a wire loop lesion over here, hyalinisation and thickening of the capillary loop. And these are all the list of conditions that you'll have to see. So there can be a membranous, there can be a mesangial hypercellularity, it can be focal, it can be diffuse, etc. These are all the various criteria. Kindly by heart this. And SLE by itself is an essay question. Go back to your Robbins. And here I am finding that there can be either a homogeneous or a granular deposit. In this case, I am seeing granular deposit at the sub-epithelial regions. So in a case of transplant kidney, what do you see? There can be enlarged and smudgy nuclei. There can be intraglomerular fibrin that can be seen. There can be a splitting of the basement membrane. Look at the basement membrane over here. It is getting split as shown by the arrow, and a double contour is made up. So there is an epithelium and there is the basement membrane which is getting split over here. And this is the source of reference. Immunofluorescence is of paramount importance in glomerular pathology. We are not pioneers. Maybe some centers you are routinely seeing nephropathology. But then remember these two things, dear students. One, it can be granular, or two, it can be linear. Granular is when there are going to be patchy areas of deposits, which are later on identified by means of immunofluorescence. They are being in the circulation and then they are getting caught in between the foot processes, etc. Therefore, you get something like the lumpy, bumpy deposits or a granular deposit. It can be sub-epithelial, sub-endothelial, or sometimes it can be caught in the basement membrane. Whereas a linear one will be anti-basement membrane, therefore it is uniformly seen. Granular. So this is a beautiful picture. It can be because of the immunoglobulins or it can be because of the C3 activity. I hope you people are able to identify the circulating immune complexes which get deposited in between the foot processes, producing the granularity. IgA again is a classical example. I don't think you will be having any doubt about the granularity in this. There is no continuity. And it is around the tubules, not the glomeruli. A short story is a shark, a sliver, and a vignette. It is a biopsy on the human condition, but it doesn't have this capacity to think autonomously for itself. And what is this shard? It is after all a broken piece. And sliver also is something that has been removed from a fragment. And vignette is something that is some kind of a material, such as wool or cotton, etc. After all, a biopsy is only this. And it does not have the capacity to autonomously explain itself. So you people should have the knowledge behind it. The eyes see the slide, but what is behind the eyes? See or know what it is. Electron microscopy. Earlier we had mentioned, and this is again a beautiful source of reference. See this one. Always capillary lumen in the center, there will be an endothelium, the basement membrane, epithelium outside, and then there will be the deposits that are seen over here. So sub-endothelial in this case. So there is an endothelium, and beneath the endothelium, there are deposits or thickening that can be seen in this case. Mesangial, sometimes within the mesangium itself, you will be able to see. Either in the mesangium, so this is a capillary to separate. Here there is a mesangium, and in that there can be deposits. So thickening of the basement membrane, homogeneous, or there can be a diffuse thickening, thinning in the case of graft rejection, transplant reaction. I would advise you people to kindly go to this kind of line diagrams wherein you people can reproduce. This is a beautiful series from Robbins itself, and these are line diagrams which you people can pick up. Kindly go back to my classes in rats. It explains renal pathology as a basis for the undergraduate, which is more than enough for you postgraduates. If you are not convinced with it, kindly go to all these references and try to improve your knowledge and comment over the subject. Thank you.